Good afternoon, John. Thank you for taking the time to let us present to you today. The consulting practice has spent the last 14 weeks since you engaged us, sort of looking into many of the obstacles to getting decent health care that are encountered by the homeless population. And our job has been to sort of advance the interests and mission of MSCC to really make a difference for this community. Just to sort of give you a sense of how the session is going to lay out, we're probably going to go for about 35 minutes, and then we'll open it up to questions. If you could hold your questions to the end, I think that would help with the flow. It's been an interesting time for us, not just for the past few weeks, but even today. A few of the students are actually graduating today and soon are going to jump off this and put on a cap and gown and have a virtual graduation. So if we lose some of our compatriots, that's why. And Caesar is actually, he juggles a lot. He is doing this from work. He does God's work with the animals at ASPCA. So if he has an emergency, he may take off, so there may be a canine issue. So just want to let you know about everything that's up in the air.
Okay.
So what we're going to do is when we're done with our session today, we will send you the slides. We are also recording this, and we will send you that recording so you will have. And by the end of the week, we will also have a more detailed final report for you. So those are our deliverables. And great. So without further ado, let's get to it. So today on the agenda, how we think it's going to lay out, we're going to have a project overview with background, a little bit about the methods we used, our findings, and obviously our recommendations. So I'm going to turn it over to the team in their capable hands, and they're going to walk you through it. Thank you.
Good afternoon again, Mr. Mudd, and again, thank you for your time today. So my name is Cesar Gutierrez, and I'll be talking with you a bit more on an organization that I'm pretty sure you're familiar with already, which is the Midtown Community South Council, also known as MSCC. It's a Manhattan-based not-for-profit established in 1983, and the MSCC encompasses the service area from the family-owned Halal Corner store on 29th Street in Lexington to the beautiful bright lights of 45th and 9th Avenue. Currently under your leadership, MSCC has 7 focal areas: arts and culture, the beautification and environment, building communities, education and awareness, homeless and community housing, urban farming, volunteer, and internships. In August of 2017, MSCC established the Homeless and Housing Committee, which meets the first Tuesday of each month, where they host a roundtable of diverse stakeholders. On January 21st, 2021, again, approximately 14 weeks ago, the Columbia Consulting Practice became engaged with the Midtown South Community Council in the efforts of assisting with the advancement of one of MSCC's core missions: to combat, ameliorate, and eliminate the homelessness crisis. Our charge was a noble cause and one that we graciously accepted. Soon came our task to help push the envelope on this social epidemic by understanding the healthcare needs of the homeless population, evaluating current healthcare diversity delivery options for the homeless, and analyzing resources in play that address the homeless healthcare pipeline. And now I'll hand it over to Morgan.
Thanks, Caesar. We've met, but my name is Morgan McGrath, and I'm excited to talk to you about some background information that we grounded our whole process in. So in 1984, the American Public Health Association declared homelessness a public health priority. So homelessness and the health disparities that are associated with it have been on the radars of public health practitioners for decades. And there have been a variety of different programs and initiatives that have been implemented and adapted since then. But today, homelessness continues to be a huge issue. As you can see, 1 out of 106 individuals living in New York City are homeless. And as you reported in your slides, 80,000 New Yorkers are homeless, 60,000 are sheltered, and there are 3,500 street homeless individuals in New York City. And the health disparities that are associated with homelessness are well documented. And we know that there's a great burden of communicable disease within the homeless population, in part because they're living in close quarters in congregate shelters. So respiratory infections, tuberculosis, hepatitis are all higher among the homeless population. Substance use disorder, which is dramatically higher among the homeless population. And then we see advanced stages of otherwise preventable disease and infection. And so when housed individuals get pneumonia, it's unlikely that they will delay care to the point where it will require hospitalization. But because homeless individuals fundamentally lack access to secondary and tertiary prevention, that usually delays their care to the point where the pneumonia advances and needs hospitalization. And something similar with septic shock and infections progressing to the point where they need some really serious care. And homelessness and negative health outcomes have a bidirectional relationship. And so by that, I mean certain health outcomes act as risk factors for becoming homeless, and being homeless acts as a risk factor for certain health outcomes. And I think one of the best ways to understand this is to look at mental health concerns. Because of our lacking infrastructure of mental health care in the United States, suffering from a mental health concern puts you in a place of precarity already in and of itself, where you're at risk for homelessness. And then if you are homeless with a mental health concern, it becomes exacerbated because there are so few ways for you to seek treatment and access care. Some of the other factors that can promote or cause homelessness are the first and foremost lack of affordable housing and eviction. And like I just mentioned, inadequate mental health care system and treatment availability. And finally, unemployment and lack of living wages. Of course, there are many different ways that factors interact with each other, but these are just the three that seem pretty fundamental. So to kind of dive into this problem, we established some methods, and our first charge was just to brainstorm what the scope of this project would look like. How do we wrap our arms around this and understand how we relate to it, and then can provide some guidance for MSCC. So we engaged in meetings with you and your team to clarify our project scope. And then from there, we dove into the literature, and we were looking at academic journals, newspaper articles, to understand what work had been done in the academic space. But we also looked at local headlines and current events to understand how people conceptualize this problem in New York today. From there, we conducted over 25 stakeholder interviews with people who were so gracious to give us their time and insight. These interviews spanned across multiple different sectors. We spoke to nonprofit leaders, private and public, hospital stakeholders. We spoke to people within DHS and the government sector. And then finally, with the housing and homeless meetings, we were able to understand who are the relevant stakeholders in Manhattan and in Midtown specifically. How do they relate to each other? What work are they doing, and how does that complement the work of their peers? And so, as you can imagine, we gathered a lot of information over the past 14 weeks, and we've organized it in three main buckets. We have contributing factors that exacerbate homelessness. And then we found a handful of mitigation and prevention initiatives that are underway right now. And then from that, we have a few key recommendations for MSCC. And so we'll start with contributing factors, and Wei is going to take it from here.
Thank you. So the first contributing factor we find is a lack of cross-sector communication. As we all know that US healthcare system is fragmented, and the issue is more significant when it comes to healthcare for the marginalized population, such as homeless population. Such fragmented network of communication prevent comprehensive and integrated care. For instance, there lacks a collaboration between service providers, The private care or street medicine providers, such as doctors from Care for the Homeless, they have no channel to partnership with a hospital system to know their client better. As such, the continuity of care is missing. This also breeds mistrust between patients and the healthcare system. And secondly, there is a poor outreach and a follow-up effort, which result in ineffective and insufficient care. For instance, although many homeless individuals are eligible for Medicaid, only a small percent of them are covered by insurance. This government program is underutilized in this case. And also, the interruption and discontinuation of care is common. When homeless individuals are discharged from hospital inpatient settings or ER, they are given a Metro card with the hope that they would arrive at their shelter or would go for their medical follow-up appointment several months later. However, this will not happen if there's no care coordinators to work on the scheduling and follow-up. So this is basically the first contributing factor, and I will hand over to Gabby for the second one.
Thank you, Wei. So the second contributing factor that came up is the mistrust of the healthcare institution as a whole. This was a major theme that cropped up in several of our stakeholder interviews, who ended up speaking to the continuous inappropriate and negative interactions that the homeless population has within medical settings, which have the effect of eroding faith in the system as a whole and in its ability to address the healthcare needs they present with, as well as in limiting the chances that the patient will end up following up on their care, which could either be through patient reluctance to adhere to a prescription or treatment regimen, or in the reluctance to follow up with a specialist or other recommended provider. And a lot of this negative treatment stems out of providers who are not actively and consciously addressing biases that they hold about this population. That is what causes some of this mistrust behind those negative interactions, are instances of provider stigma, where they're not consciously checking themselves on their biases, which ends up impacting the type of care they provide and the type of interactions that they have with this population. Alongside this is a lack of trauma-informed care in medical settings, which means that anyone, the medical professionals, the staff, whoever it may be, fails to take into account previous negative experiences that this population has had with the healthcare system, and may end up acting in a way that is just compounding those issues and that problem. And what we've seen, what stakeholders have reported from these individuals that they interact with, is that this mistrust comes from the discrimination they feel against them, diagnoses that they believe are unfair because the provider isn't either giving them a voice or seriously considering the impact of their housing situation on the patient's ability to address their health. And it leads to them not adhering to follow-up care. For somebody who's spoken down to, who isn't involved in their own care, who's being interacting with somebody who's being discriminatory towards them, they may not feel as if they have their best interest in mind when they're providing them with a follow-up and treatment plan that isn't taking their situation into account. And all of this ends up leading to an overall poor experience for the homeless population. And now I will hand it off to Tisha for the third factor.
Hi, I'm Tisha, and I'll be telling you about contributing factor 3, which is the NIMBY effect, really not in my backyard effect. So really here, not all the community members are really eager to allow homelessness prevention and these mitigation programs in their neighborhood, in their community and surrounding environment. And the attitude of those who really support a program or even an incentive in theory are really supporting this at a more distant kind of area, and really not interested more in practicing it in their local community or local environment. And so really it's that belief that renewed and robust social service programming really will attract this homelessness individuals, and then it will eventually lower the local business revenues, the property values, and even the neighborhood vibrancy. And I'll pass it off to Victoria for contributing factor 4.
Thank you, Disha. Good afternoon, Mr. Mudd. Again, my name is Victoria, and I will now be talking about insufficient referrals beyond the medical setting. So another issue mentioned by stakeholders was actually that medical providers were not well experienced on best care practices for homeless individuals beyond the medical setting, and they didn't provide sufficient post-care referrals. These include referrals for things like medical respite bed programs and shelters, for example. The two main reasons for the lack of referrals were, one, that physicians feel as though they don't really have enough time during each patient visit, and two, that they think it's actually outside the scope of their work to do so. As it is, physicians already feel as though they don't really have enough time in one patient visit to give to each patient, let alone referral services beyond their care. In fact, according to the Agency for Healthcare Research and Quality, more than half of primary care physicians report feeling stressed because of time pressures and other work constraints. At this current state, care coordinators would need to step in and provide those services to the homeless patients before the patient leaves. I will now be handing it off to Morgan to introduce mitigation and prevention initiatives.
Thanks, Victoria. So now we're going to shift into that second bucket of mitigation and prevention initiatives, and Wei is going to kick it off.
Actually, I'll be taking this one, speaking a bit on safe havens. So the first mitigation and prevention initiative that we'll speak about are safe havens that, as I'm sure you're aware, are a type of low threshold model of shelter care that was created back in 2006 by the Bowery Residence Committee, or BRC, for the purpose of targeting the underutilization that city shelters were observing. They were going empty because of a lot of complaints that the homeless population had about the strict structure of these shelters. So what BRC did was they took feedback from the homeless population and built a new model around that. The new components that they put into place included having private rooms, so not having to share with several other individuals. A low case manager to client ratio was established, which also allowed for the provision of more intensive social supports. And there was unrestricted entry and access into the safe haven, which eliminated that curfew requirement that city shelters had, that certain members of the homeless population felt really restricted the independence that they would have otherwise had on the street. And lastly, sobriety was not required. Once again, eliminating a requirement that was otherwise put into place in city shelters. In using all of these components, BRC saw a very successful model in this initial safe haven, which prompted the opening of several other safe havens across the city through partnerships with the DHS and community organizations, to the point that they're currently oversubscribed with the amount of individuals who want to get into this otherwise very successful system. And next, I will pass it off to Morgan.
So now we're going to talk about combating NIMBY, which is no easy task, but the top priority when engaging in this work has to be combating the myth that Tisha explained earlier about how health and social service programming for homeless individuals is somehow going to attract or promote more homelessness within the community. And we know that this isn't true. We have plenty of evidence that does not support this myth. We know that homelessness is already a problem in the Midtown neighborhood and in New York City more generally. And so more transparency in problem definition and the scope of the problem will actually allow for more appropriate and effective approaches to addressing it. And so it's less about deciding whether or not this is an issue in our neighborhood, because we know that it is, and more about how we choose to put resources towards it to prevent it. And so one of the key ways that we think that MSCC can be doing this is actually something that you all, I think, are already doing, connecting one-on-one with skeptical neighbors and business partners and otherwise people who are not sure how they feel about these initiatives, to kind of humanize the programs, and connect with people, just in a really intimate setting. Education trainings that are grounded in the power of storytelling, have incredible reach, and they amplify the experiences of homeless neighbors, in a way that builds empathy and inspires action. I think one of the most captivating parts of this project early on for all of us was hearing about how you had, firsthand supported so many individuals through, the healthcare system, and that really matters. And so carrying those stories throughout all of, your efforts to combat NIMBY, we think is going to be important. And a recent example, and one to follow, Goddard Riverside is currently navigating NIMBY, in the Upper East Side neighborhood, because they introduced plans for their 91st Street Safe Haven, which they hope will open, early next year. And initially the community was on board, but as more and more people found out about this and, publicity started to spread, the skeptical neighbors started to voice their concerns, and now, Goddard is having to field those concerns and is, hopefully not going to have to backtrack too much, but, the timeline has certainly been adjusted. And so now I'll give it to Wei.
Thank you. So our third initiative is a medical respite program. As you may already know, medical respite care is acute and post-acute medical care for people experiencing homelessness who are neither ill enough to need hospital level care, nor well enough to recover on the street or in a shelter. So medical respite care is a supportive medical step-down service in a home-like environment that provides holistic, post-operative, and recuperative care to homeless individuals. And it is a critical component to ensuring continuity of care for the homeless individuals. It emerged in 1980s in US, and the need has grown since then. So currently there are 116 programs listed on the National Healthcare for the Homeless Council. The major component of medical respite bed are funding, service, and model. Most programs in the US are funded through Medicaid or paid by managed care organizations, MCOs. Nationwide medical respite program provide medical and a wide range of non-medical services, depending on the model. If a program is located within or operated by a federally qualified health center, FQHC, then medical services are usually provided on site. Other models, including a respite program within a shelter or in a transitional housing facilities, usually they partnership with the healthcare organizations for medical services. And some of the programs, they do not provide medical services. And that there are two models in New York City, Manhattan, that are involved in the medical respite program. They are New York City Health and Hospitals partnership with Community Life, and Mount Sinai's partnership with Community Life, and Institute for Community Living, ICL. So they are both a partnership between homeless service organization and a healthcare organization. And one is a public hospital system, and the other is private, but they're taking the similar approaches. As you may already know, Community Life is a long-term respite program. It has a maximum of 90-day stay, while ICL is a short-term 25-day stay program in our transitional housing facilities. Now I will hand over to Gabby for the fourth one.
Thank you. And so I'll speak a bit about insurance enrollment, which is the fourth initiative that we identified. And it came up through discussions with Dr. Andy Coyle. And from him, we learned that of the homeless population that his team sees in the hospital, about 30% of those who are eligible to receive Medicaid are not in fact enrolled. And he stated that this is a limit for both the patient and the provider, and the type of care that they're able to receive. The type of care that's able to be administered to the patient is restricted in where they'd be able to go, what they're able to get, and the provider is also restricted in the type of care that they're able to provide. So one initiative that has been in place for several years already is the use of publicly funded programs, both city and state, to help any and all eligible New Yorkers get access to insurance. And this includes the homeless population. So this initiative uses qualified individuals called either facilitated enrollers, mainly in the state program, or certified assisters, who are more so in the individual nonprofit organizations. And they are trained to educate the eligible individuals, help them learn about their different options, and in some cases, after assisting with the application process, actually continue to go through with them until they receive enrollment. And so the Navigator program is actually a specific program for insurance enrollment that is purely made up of individuals working to assist New Yorkers with getting access. But then there are also shelter and nonprofit staff scattered across the city in various community organizations who are on hand to help assist, particularly with enrolling the homeless population. Now Victoria will speak to our next initiative.
Thank you, Gabby. I will now be speaking on electronic health record sharing. So electronic health record sharing, or EHR sharing, is the ability to send and receive a patient's health information among multiple healthcare sources, such as between hospitals, clinics, and urgent cares. At this current state, medical providers actually lack universally agreed upon ways of sharing and using information for the transfer of patient data between different health record systems, mainly because each medical facility uses their own medical record platform. So this is especially consequential for the homeless population, as they are constantly moving between different healthcare systems to receive their care. This disjointed care becomes especially problematic for the patients because their care providers are not up to date on the patient's most current medical information, such as prescriptions, other doctor visits they've seen, dates they received care, and any new diagnoses or procedures they've had. Without this information, homeless individuals are actually at a higher risk for enduring unnecessary and repetitive tests, receiving inaccurate diagnoses, and spending extra time in these healthcare facilities. With that, I will now be handing it off to Cesar to discuss street medicine initiatives.
So the Street Medicine Mitigation Initiative has both a social and a medical approach when it comes to addressing the injustices of the homeless healthcare pipeline. It was initially envisioned by Dr. James Withers, also known as the father of street medicine. This medical practice focuses on bringing the care to the people, which already eliminates a huge barrier that many homeless individuals face. Street medicine efforts are carried out in relatively small groups of about 2 to 4 individuals, so as to not excite or startle the homeless patients they hope to serve. Street rounds, as they have come to refer to it as, generally occurs between 3 to 4 times a week, where the team will first build trust with patients and reinforce core team values amongst each other via the handing out of basic needs such as toiletries, blankets, water, etc. This same team will be present throughout the patient's medical journey up until the patient handoff with a partner medical facility if necessary, such as patients in need of a medical respite care. The team members include a primary care physician. Oftentimes they're from partner clinics to help continue with continuity of care, or they happen to be physicians leading their own private practice. A nurse navigator, which are licensed registered nurses that also serve as caseworkers in terms of care coordination. Their main focus, along with assisting the primary care physician, is to help during navigation of healthcare systems. A community health worker, similar to the nurse navigator, but without the medical expertise. These individuals help with the gathering of proper documentation, applying for insurance, navigating healthcare systems, and in some cases, housing. And finally, we have either a psychiatrist, a social worker, or in some cases, both. And these are individuals that are properly trained in appropriate de-escalation techniques and have a better understanding of how to safely approach, introduce, and handle potentially mentally ill patients. And now I'll be passing it off to Morgan.
Thanks, Cesar. So with all of that background information and findings, coming up are our recommendations. And Wei will start first with medical respite beds.
you. So we have mainly 3 recommendations for MSCC in terms of medical respite bed. The first is to partner with Mount Sinai or New York City Health and Hospitals in their ongoing efforts. Both of the systems have a comprehensive set of initiatives to tackle the healthcare issue for homeless individuals. In New York City Health and Hospital Bellevue, there is an interdepartmental and intersystem dashboard to identify homeless individuals. Then these patients will be approached by the homeless clinics at Bellevue, and they will be covered by a Metro Plus health plan, a Medicaid MCO owned by the New York City Health and Hospitals. In 2017, the plan established an Integrated Care Management (ICM) program that provide care coordination services for members with complex care needs and those ER and hospital service heavy users. And recently, Bellevue started a mobile unit for street outreach and street medicine. So we think it has a series of infrastructures and initiatives in place for the homeless individuals. On the other hand, for Mount Sinai, its homeless service include internal medicine associate, social worker, and then a medical respite pilot program, and an early identification tool similar to HSC's dashboard. On top of that, Beth Israel Medical Center Transformation Project, which was initiated several years ago, does incorporate medical respite bed and a comprehensive behavior health center. These projects are to meet the demand of the community. So we are happy to see that both public and a private healthcare system in the city are engaged in building a holistic ecosystem for homeless individuals' care, and that they take medical respite program as a critical component. Since Midtown South area is surrounded by Beth Israel, Mount Sinai West, New York City Health and Hospital Bellevue, we think MSCC would be a great community partner for these healthcare organizations. And the second, our recommendation is to support Ryan Charles C. Health in creating a respite program with on-site medical service in their facility. We have several reasons for this recommendation. First, Ryan Charles C. Health is a federally qualified health center, and it has a proper infrastructures, including care facility and providers, mobile unit for street medicine, and also it has a sustainable partnership within a community. Therefore, if Ryan Charles C. is involved in a medical respite program, it's possibly to become a program with an on-site medical service in the facility, which is very attractive and would be the first in New York City. So together with MSCC's rich resource in the homeless service, it could be a great program moving forward. Also, we think the opportunity exists, particularly after the New York State passed its 2022 budget, which include a medical respite pilot program. Although it is still not clear which pilot program the state is going to support, I think we think Ryan Charles C. and MSCC could have a try. And the third, which is also very important, is that MSCC should advocate and work on adjacent social service programs alongside with respite initiatives. Several interviewees emphasize the need for these complementary programs such as harm reduction, housing assistance, insurance enrollment to be introduced to work in tandem with respite. MSCC is in a strong position to engage stakeholders in the Midtown area with its connections within the community and among different social service agencies. So we think MSCC could do a good job in this aspect. So these are the 3 recommendations for medical respite. I will hand over to Victoria for the EHR.
Thank you, Wayne. So there are 2 main solutions that can actually be utilized when trying to promote the sharing of electronic healthcare records between patient and provider. The first option would be to create a device for patients, such as a medical ID card or even a medical bracelet that could actually be scanned at a medical facility and would instantly upload their medical records for their physician to access during that visit. This approach would allow health systems to continue using their respective electronic health record platforms. Additionally, the physical medical record devices could be useful during something like an emergency when a patient is deemed unresponsive and is unable to verbalize their medical history to their caretaker at that time. The second option would be to have healthcare centers all utilize the same health record database so that they could communicate without needing a patient to carry their information on a bracelet or a card device. There are several drawbacks to this approach, however. For example, it would require all users of the EHR system to learn how to navigate and utilize a completely new system. This would not only take time, but it could also slow things down in certain medical settings. Additionally, it would also be really expensive to obtain new software. Finally, a privacy-related concern is that a homeless patient would have to provide their real name to medical staff in order for them to view their medical records. So it's definitely something to keep in mind when considering the second option. And with that, I will now hand it off to Cesar to discuss street medicine recommendations.
Our third recommendation would be becoming active and getting involved within the Street Medicine Institute, which would put you directly in contact with multiple different street medicine outreach programs. This organization was founded by Dr. Withers with the same goals and principles that you have shared on addressing the homeless healthcare pipeline issues. It's actually the partner group that Dr. Munson is working under via the Barbara McGinnis House program right now with their homeless initiatives. So the Street Medicine Institute, as I mentioned before, is an internationally renowned network that boasts thousands of street medicine group programs, several within New York City, such as the SUNY Downstate Street Medicine Outreach Association, which is a student-run volunteer effort that works on healthcare inequality for this vulnerable population by delivering first aid and basic preventative care through street outreach engagement. The Ryan Chelsea Clinton Homeless Clinic Initiative, which also serves as a vector of bringing the care to the people. And as recently as 2019, street medicine was actually proclaimed a citywide priority by Mayor de Blasio to help combat this growing issue. It's recommended to join the Institute simply because it's been shown that many times when groups intend to do well and get involved with street medicine care on their own, it actually causes disruptive care in the homeless individuals and healthcare journey, which can be more detrimental than intended. A yearly street medicine symposium is held, and if MSCC were to register for the symposium coming up in July 2021, the first day serves as Street Medicine 101 session, which further explains the field and how to best get involved. Also, once you're registered under the Street Medicine Initiative, you're actually going to be able to network and connect with any of the hundreds of street medicine initiatives in New York City for future partnership opportunities. And now I'll pass it off to Gabby.
Thank you, Cesar. So for our fourth recommendation, we have the expansion of insurance enrollment initiatives. As mentioned before, a path to Medicaid enrollment already exists in New York for the homeless population, but it's not very incredibly targeted towards them. With approximately 1/3 of the eligible individuals not taking advantage of that initiative to its fullest, we propose expanding the number of facilitated enrollers in shelters and community organizations across the city so that all of these organizations have someone on hand to help assist their clients. But we also propose stationing some of these facilitated enrollers in the hospital and ED setting, since that is where a lot of uninsured patients are found and would be a better means of capturing who it is that actually needs these efforts the most. An important consideration to note with this suggestion is that it would absolutely need to be coordinated with the health system so that it's seamlessly integrated into both the intake and discharge process for the patient so that everything can be taken care of appropriately. And I will continue on and speak to our fifth recommendation, which has to do with putting into place a type of ER adjacent drop-in center for those homeless individuals who tend to go to the ED but may not be the most appropriate for care there. So because homeless individuals often use hospital settings, despite lacking either non-urgent or actual medical needs, several stakeholders have spoken with us about the possibility of setting up an alternative location for these individuals to go to that would better be able to attend some of the basic needs they present with. So as stakeholders have noticed, this would decrease inappropriate utilization, save the hospital money, and probably improve the type of care that this population sees given their poor previous experiences with the ED. And this would be due in part to the need to partner with community organizations to set these centers up, which could take the form of either a mobile medical unit, or a temporary tent located in the parking lots, or a drop-in center in the hospital, or otherwise immediately near the hospital, because proximity really is key for this initiative. And this could be a model that is community-centered, leverages those community partners who are already familiar with the population and how to work with them, and would be able to provide patient-centric, trauma-informed, and comprehensive care to this population. And now I will hand it off to Tisha for our sixth and final recommendation.
Thank you so much, Gabby. So I'll be concluding our recommendation section with the sixth recommendation, which is really implementing a housing and homeless clinical coordinator. There really needs for a standardized protocol for discharge for homeless patients from the ER. The discharge patient for homeless patients is really different enough from that of housed patients to really warrant a housing and homeless coordinator to really orchestrate this process. The homeless clinical coordinator would really integrate and ensure a smooth transition from the encounter to the discharge. So kind of the entire journey within the hospital to them leaving the hospital setting. They would also really create a unified way to make sure the system functions and really facilitate social service partnerships. Lastly, these coordinators would also take into consideration and make sure to document the financial costs associated with the treatments and sources of potential payments. And ultimately, this would aid physicians who that we've seen become frustrated with homelessness patients who continually come in for treatment with little documentation or background about their health and history and records. So that is the final recommendation. And we would like to thank you for really guiding us through this journey and giving us your time to listen to our presentation. And now we are open for questions.
I think you're muted, John.
Yeah.
Very good. Very good. That was brilliant. Great work, everybody. Yeah, let's see, count of homeless. Okay, number 5, slide number 5, count of homelessness. Okay, these figures change, you know, depending on what source and year and whatever. I noticed the 80 is now in the past 2 years, it's been 92, 91. So just want to make that note. I'm not sure how to incorporate that where it's flexible, or do we just change it, or
we can change it. It's
yeah.
no big deal. Easy on a slide and easy on the report. Thank you.
Yeah.
Perfect.
I found the source for those numbers was the HUD's annual report, and I think those are from 2019. And so I'll pull the most recent numbers.
Okay. I did mistrust of medical number 10. I get it. Yeah, I understand it. NIMBY, number 11. Can we pull up number 11, the NIMBY slide? There you go. Okay, yeah, we get a lot of that. SIS program we're promoting, we got new bills, and everybody's frightened that it's going to draw people in. into the community. We get a lot of that. And you're belief. Okay, so I think you covered the rebuttal. What was your rebuttal on those issues again?
I don't know if you want to, but I can speak to that, I think, a little bit. I mean, first of all, education and telling compelling stories. And we've sort of looked at what Goddard has been doing on the Upper East Side. And of course, it's not open yet, so we'll see. But for many months, they sort of laid the groundwork, working with political leaders in the community to sort of say, look, this population's in the community already. They're in the subways. They're underneath scaffolding. They're everywhere. This is now getting them proper care and services. This will actually get them off the street. And so it's not a magnet to come into your community. It is a solution. So we think through education and storytelling in pointing out that it's actually part of the solution, that maybe, you know, there are always going to be people who are fear mongers, but there are people in the middle who I think if you make a compelling argument with laying the groundwork, you can sort of combat this. That's sort of our thought about, you know, how to deal with this.
How, okay, let me go to an example. I'm having a situation now in Midtown where they're really focused on moving the shelter out. They wanted me to sign on with them on letters. They've got formulated a group. Let's move the shelter out. That's their mantra. Let's get them vaccinated. Let's get them back to their congregated shelters. Let's move them out. My stance is I don't want to make a bad thing worse. They're here. This is ongoing decades and decades. I'm tired of Band-Aids. There's no point of it. We need supportive services and housing, and I get a lot of heat. Now, of course, the homeless and housing meetings there. I have these council meetings. I'm constantly reiterating my point. I even get shut down sometimes, depending on sometimes someone would come in and pack the room with people that have their same interest in mind, and they're trying to prevent me from speaking at times, and so and then of course community boards, you know, they've worked it pretty well. They went to the garment district, went through business bids, got them interested in letters, had some press done. And part of the community board is divided. Now, besides putting it on the YouTube channels, putting it out there, having these meetings, maybe, and then that's a lot of work. That's a tremendous amount of work. Besides the articles, I mean, it's just their voices are usually louder because any incident that comes up adds impact. You've got the New York Post put out 3 articles recently in a row, and they're horrendous articles, and they're slanted, and they're absurd. So you've got friendly news organizations that you know, puts it out there in a very hyperbolic way, and the fellow that was on 40th Street shelter that beat up the elderly woman did not help whatsoever. So they of course focused in on that, and then the precincts are behind, let's clean up the neighborhood. You know, it's like some backwards police force that we've already been through over and over, and that they don't have any intelligence about how to handle it. And I've recently had trouble with them. So with that in mind, I think it's really about getting people together, the agencies, and do a marketing plan. I can't think of anything at the moment, any besides these engagements. Sounds like these engagements you're talking about are on smaller scales and group scales, right?
So, not to cut you off, Mr. Mudd, but
Right.
it's interesting that you brought up that actual hypothetical, because it's something that we've also kind of asked ourselves during the planning process and recommendation process. And one thing that came up quite a bit, and I believe it's included in our final paper, if I'm not mistaken, is getting someone from the community, the homeless community, to actually be the advocate and almost the face of the initiative that you're trying to drive. Because we also heard about the news of the gentleman that beat up the woman on 40th Street. And it absolutely, a bad apple does definitely seem to tarnish the bunch, but that's not the case. And I believe we all know that there are bad people and there are good people, whether homeless or not. And so finding somebody that can serve as a quote unquote model example of either a rehabilitated homeless individual or an individual that you guys may have partnerships with already, that can be your person to help pioneer the way of not all homelessness is bad. And they can also serve as a mediator between the actual homeless community and serve as an example of this is what it's like when we actually partner with them, instead of being fearful of a us versus them kind of attitude. Because just like people don't want them in their backyard, homeless individuals we found also have sentiments on how they're viewed and how they react to not just medical individuals, but the public as a whole, being often overlooked when they are only seen as beggars, when in some cases they may just be asking for directions to find the shelter. So things of that nature. So being able to go out there and it's not only to do it on a small group level, but also being able to actually build a relationship, especially with one or two, potentially bringing them into your council just to serve as the voice for the voiceless in this situation. And then that way you can take them to any partners that you have on the post and they can have their articles and their voices out there. Because sometimes I can only imagine how someone who is homeless ended up homeless. But if I can actually see their side of the story and sometimes that puts me in their shoes, then it already creates, it destroys so many preconceptions that I may have had or not. So that was one of our big recommendations. It was just a little bit harder because it takes a lot more outreach efforts. And we understand that the team at the moment at MSCC is a bit spread thin with all of the initiatives that you're getting involved in, but it was one that was floating around.
Excellent, excellent.
I also think that this type of health communication is pretty core to public health in general, because all of the issues that fall under the public health umbrella are urgent, and all of them also have systemic factors. And so, quote, Band-Aid solutions, and then also further upstream interventions. It's more of a both and, I think. If there are people who are just interested in Band-Aid initiatives, I think at least motivating them to see the systemic factors that are at play, so that when there are cases like the one on 40th Street, you're able to name the lack of resources that individual had throughout their entire life. And so you can say, look, this is what happens when we deny people these basic social services. And that's the type of change that I'm interested in. And so in the short term, of course, we need to be implementing programs quickly overnight, but we also have to be working to move further upstream so that we don't have to be implementing these Band-Aid programs down the line.
Excellent.
I know you have other things you want to talk about, but just my final thought on this, when you mentioned sort of a marketing plan, it seems to me that sort of an accurate tracking of the mobility of the homeless population would probably indicate that it is not simply the existence of a shelter or services that draw people into the neighborhood, that it's sort of like a false dichotomy. No shelter, that you won't have this problem. That's just not the case. If the shelter is not there, the person could just be sleeping under the scaffolding or could be walking 10 blocks. This is New York City. People get on the subway, people walk everywhere. that incident on 40th Street could have happened from someone coming from a different shelter or not in a shelter. So it's sort of like a cheap shot to associate the shelter with the problem. The problem is the individual wasn't getting the care he needed, and that danger is anywhere, whether or not there's a shelter or not. In fact, it makes it more likely that you have more incidents like that when you don't have the services. And somehow that needs to get conveyed, that this population is sort of going around, and you can't just clear them out. This is a free country. So that incident could have happened no matter what, whether there was a shelter or not. So we need to move on, I think, because you probably have questions on other topics, but it's a difficult situation, John. We understand that. People talk about their kids and schools, and they go right to like one place, and then like it shuts down the whole discussion, right?
Yeah.
Right. And what are you supposed to do?
Exactly.
Right.
And then you're the bastard for ignoring their kids' welfare.
Right.
Or yeah.
Right.
And yeah, I got yelled at once.
Yeah, but it's as if the problem will magically disappear if you don't have a shelter.
Yeah, exactly.
It's a false dichotomy. So somehow that point has to be made.
Yeah.
Right. They're not all going to Staten Island, right? It's not happening. So anyhow.
Excellent. I wish I had your voices with me all the time and around me. And more people with different point. You're facing people, and you might argue one point, but then it's hard to keep up with such impassioned people sometimes. But anyway, insufficient referrals, I thought that was great. BRC thing, 30% Medicaid. Medicaid. So that was amazing. 30% not insured properly. That's pretty amazing. I didn't think it was that much, but that's a wonderful figure. And that shows, yeah, and maybe if that was corrected, even that cut down, and all this process you're talking about would do that. You wouldn't have such emergency room incidents, and you'd probably save lives and help them on. Once you get, I think, down to the bottom of the barrel with your illnesses and everything, it's just so much harder to climb out. So that was wonderful. Record sharing, great. I think your report will probably add more to it. I know I had some questions there. The street medicine, de-escalation technique. Do you have the de-escalation techniques they're using? Do you have a
like the protocol, like the steps and things?
Yeah.
So I spoke with the Allegheny Health Network about that, but unfortunately she shared that she wouldn't be able to divulge that information. And apparently it seems that it's somewhat different across the different organizations that utilize it. For the most part, it's, if you were to, she just kept mentioning the Street Medicine Institute and how they have like each day would kind of present you a different thing. So I believe that one of the days, if I'm not mistaken, is how to properly approach that, even if you don't have a licensed psychiatrist or social worker on your team presently.
Yeah. Did you look at, were you able to get any kind of de-escalation protocols from anywhere?
No, the most that she was able to offer is the fact that they go in small teams to just not incite it to begin with.
Yeah, I think the police department needs that really bad. Not just with dealing when they want to come in there and deal with homelessness, a person with who is homeless, but just in general. But I thought that was interesting.
Can't say I disagree, but
yeah. Ryan Chelsea, Ryan Chelsea Clinic is one of our good partners. And Beth Israel, we've been talking, we had a discussion about using that as a medical respite bed. They got several wings. Did you come up with any kind of numbers as far as how many units, rooms that would help, that would control a medical respite bed that would because at NILAG, I think they had some small units in every borough. Did you come up with any kind of units?
We do not have sort of a recommendation or an estimate. You know, I think New York is behind a lot of other places,
Mhm.
including California on this. And I think we're on the cusp of this thing taking off. And I'm not sure what the right number is going to be about the need and the capacity to fill it.
Hmm.
We do have something in our detailed report about the Beth Israel facility and some of the challenges of trying to convert it to medical respite use. We did speak to some people there. You know, when wings are sort of mothballed, they really cannot be, you know, some easily brought up to code sometimes. So I think you will get some pushback on that. I think Mount Sinai believes they're sort of among the major healthcare providers that they're sort of one of the good guys compared to some other hospitals we won't name, who, you know, don't sort of have so much interest in this space for this population. So you know, there is you know, they're building that behavioral health facility in the old Rivington House, I believe. And so they've got some initiatives going on. Anyway, you'll see it in our report, but I think there are some challenges about the Beth Israel facility. I know like Arthur Schwartz was quite sort of gung ho, but you're going to get some pushback, I think, John.
Yeah, on both, not only just medical respite bed, but you had talked about shelter.
Yeah, I'm not sure that they sort of know exactly what they want to do and how they're going to sort of de-mothball it, but I think the electrical infrastructure and other things are just not in great shape
Hmm.
right now. So I don't think it's just like turning on the lights and having people come in,
Right,
is my understanding. So,
right, okay.
yeah.
The electronic systems, did you did you talk about a recommendation? You said, I think you mentioned new system. The systems aren't working together. You have new system, but did you recommend a particular system?
No, not a system, but I guess what we think is there should be a technology fix for this. Just like people have medical alert bracelets, and you know, if you go in the hospital now, and they give you your bracelet and you're an inpatient, the first thing they do whenever anyone approaches you, a nurse, a doctor, whatever, is they scan your bracelet. There's a code in there. And your information comes up and it says what your medicine's supposed to be, if you have any allergies, like your whole story comes up when they just take a scanner and they go over the code. And we thought, why not have that technology for this population? You know, because they are transient from healthcare provider to healthcare provider. And if they don't tell their story about what treatment they got last week, what medicines they're on, it starts from scratch, and their potential contraindications, that what they're given compared to what they had. No one seems to know that they had tuberculosis and recovered. So how do you do it? So either with like a card or with a scannable bracelet that every time they have medical care, somehow it's added to their record, and they sort of bring it along with them, and they show up in the ER and someone just scans it and says, aha, 2 months ago, he was treated for the same thing. Or, you know, he had a wound that didn't heal. And so we don't have a technology recommendation or a provider, but there have to be people who can sort of go into this space and start with this population, I think, you
Mhm.
know,
Yeah.
if they're willing to sort of overcome some of their privacy concerns. But there's got to be a way to track their outcomes and their continuity. That's sort of how you sort of create the pipeline for what's happened. Otherwise, they're just getting disjointed care, duplicative care, and contradictory care.
Yeah, I had seen that firsthand, exactly what you're saying with Alejandro. Certainly.
Yeah.
The slide number 24, street medicine. I know you mentioned something about signing up for that, and I do want to. You'll have to give me, and I'm sure that's in the final report, and I definitely want to jump on that. Uh, It sounds like a pretty effective means, but I think you also said that there was a problem with a person having regular care, and I kind of missed that or misunderstood it or didn't quite grasp it. It was in slide number 24. I think you mentioned someone medical care and street medicine, and there was a conflict or something.
Yeah, I can take that. So Caesar's interview with one of the nurses from the Allegheny Health Network, she revealed that there's a lot of hype around street medicine because it is a really effective model for delivering care. But there's this whole centralized, essentially database, which is the Street Medicine Institute, where best practices and information are all held. And a lot of people are getting excited about street medicine, forming their team and going out on Saturday. And without necessarily proper context for what the healthcare challenges of that specific neighborhood are there other street medicine teams that are already doing this work? Are these patients usually served by the clinic that's around the corner that you have no idea about? And so her warning was just that there are a lot of cooks in the kitchen. And so make sure you know which cooks are in the kitchen that you want to join before you join, because you could be just adding to their team rather than starting from scratch.
Which is probably the benefit of maybe partnering with the Street Medicine Institute to have coordination and some resources and protocols.
Okay. You mentioned partnering also with Mount Sinai and I think another one, and also Ryan's Clinic on other things. What about in all the cases where will Chelsea Ryan Clinic, can they fill in not just what your recommendations are, but also what you recommended for the hospitals, or they have some lacking infrastructure that prevents that?
With respect to coordination and advocacy, or
yeah, I think it was you mentioned Mount Sinai. It was. I don't have, my notes are a little
okay, so
sparse. So there's a lot to tackle here. There's a lot of things we can tackle. In that final report, do you have any summary as far as how we might get the job done?
I don't know. I don't know how to speak for my team. I would say this is, a thought piece, a thought-provoking piece that is the groundwork for next steps, is how I think I would describe our efforts. If we had more time, if we weren't COVID restricted, I think we could take the next steps, on a more granular level based on your feedback, for you to say, okay, this is where I want to go with this. These are the 10 things I want to know on a practical basis to follow up on. And we could run with that, John. And I'm not sure, I don't think there's probably a consulting practice from mailmen over the summer, but there definitely is in the fall. And I would urge you, if you're interested in this, to reach out to John Winkleman and say, hey, I'd love to sort of build on this, right? This is based on this foundation. This is where I think, because when you first approached us, there's so much to be done. You were like, you were here, and we wanted, where should we go? And so hopefully this can direct you to then reach out to us again and say, this is where I want to go with this. This would be the most use to me, right? And we take it from there, is what I would say.
Yeah, okay. I'm thinking that sounds great, and certainly I'm going to do that. Take that recommendations. I want to do that. I'm thinking I need to get people to see this. Some of my closer partners, Chelsea Ryan Clinic, Mount Sinai, some council people, DHS. So I want to pull them in first to review it, look at the slides, look at the report, review it, and see if we can start to pick things off one by one, or there's a lot of things I think could be effectively handled. There's a lot of things. I mean, they certainly have to have money for. I know they're working on communications infrastructure. They have to see this as a very important part of communications and infrastructure. I know they're spending money on it. Sometimes I wonder if they do it properly. I mean, when we did our homeless and housing report, we saw this 311 and 911 issue, and we sent it to the DOITT, and then they did work on it, but they still didn't finesse it completely. So I think I'd like to do that, and I'd like to have the opportunity to invite you there too, in case there's some questions that come up since you've done the research. I don't know how you feel about that, but
okay, I have to check with my team and certainly my availability, but most of them are going off to greener pastures, graduating, I think. So I wouldn't presume to speak for their time and their efforts, but sure. I mean, let me know what you want, and we'll see.
Well, you definitely should. If you have the opportunity, free time, I think it would be it'd be good for you. Good to have you there.
Okay.
And certainly I'll and it'd be easy to do. I mean, the slide information, the way you present it was great. And then when it comes to discussion, we can cut my stuff out and start fresh. So
no, actually, your discussions are sort of they're very instructive, and they're sort of the roadmap to where things need to go, because you're on the ground, been dealing with this for a long time. So this is added value when you question us. So
good. Yeah. I think also I've been wanting to show this pipeline, this chart, charted out. I think we have to have a master chart or something, but
well, I hate to keep going back to COVID, but if there was no COVID, we would have liked to have followed, a patient on a journey,
Yeah.
right? To actually have interaction. They came in, they were in this shelter, this happened, they went to the hospital, they were there for this long, they were then discharged to here, this happened, and followed their journey or whatever. We're just in a remote world right now where we can't do that. But I think that would be instructive, just like you did with Alejandro personally, with your experience.
Yeah, yeah, yeah. It's the best way to really see it.
Yeah.
I'm thinking I'm in touch with Rescue Mission Josiah about I'm negotiating on a space over here. It's 1,500 square feet over on 9th Avenue. Shower power, they're interested. We were looking at Housing Works, but they're doing their own space apparently. The most important things I think that jump out at me is of course the housing connect, trying to get, oh yes, but embedding in, I think you had discussed this during the slide about embedding people with more how, like a coordinator, I guess, like a better word.
Yeah.
But I think between that and some medical services and communications and outreach, a small unit would be pretty effective, I'd imagine.
Mm.
If you it's take maybe 3 or 4 of those main things. We're thinking it'll be effective. Yeah. But yeah, okay, cool.
Great.
Thanks so much. So we're meeting final, or you're just sending stuff, I think, right?
Yeah, this is our final meeting, certainly, but you can certainly reach out to me and I will make myself available. Today's Wednesday. Hopefully by Friday, our plan is to get you our slides. We'll try and just update the numbers, like the 92,000, something like that, a final report, and we will, Morgan will figure out the best way to get the file of the recording to you. So you'll have all 3, and you'll have some things to digest. And please reach out to Professor Winkleman, reach out to me, and where we sort of go from here on it.
Great. And yeah, if you guys want to be on my e-list, like for the, I think I put you guys on my mailing list, but if you're leaving, I guess you change the emails, you're using the school's emails, but if you have a personal, if you want me to put it on e-list, if you want to keep abreast of it, and excellent work. I can't thank you enough.
Thank you.